distributed and used in whatever capacity you choose. So enjoy. To begin with, we can qualify. Good day, and welcome to the second installment of 3 installments of Cranial Nerve Podcasts. Once again, this is Dr. Stuart Ingalls. In the first installment, we gave a general overview of the cranial nerves with an emphasis on identifying them as they come off the brainstem and disappear into their respective foramina. In the second podcast, we'll be taking a much more in-depth look at the first 6 cranial nerves and what happens to them once they leave the skull. We'll also be considering some of the clinical applications accompanying damage to these structures. As you might expect, the final installment will discuss the last 6 pairs of cranial nerves. As previously mentioned, all the material used in this video is either licensed through the Creative Commons or is considered part of the public domain. This means that it is completely free of copyrighted material and can be circulated without restrictions. So if you do find it useful, feel free to download and circulate with my blessing. I've also included a link to download the PowerPoint presentation that this podcast is based upon, which can once again be distributed and used in whatever capacity you choose. So enjoy. To begin with, we can qualify each nerve as being purely sensory, purely motor, or mixed. Once again, mnemonics can be useful here, and we can use the expression, some say marry money, but my brother says big brains mean more. Note that the term brains is often interchanged to a certain other anatomical terms, but I'm trying to keep it PG here. We start with the olfactory nerve, which is strictly sensory for the special sense of smell. In this mid-sagittal section, we can see the nerve fibers penetrate through the cribriform plate and branch into the superior mucosa of the nasal cavity. Whenever we breathe in, the conchae mix around the air, allowing chemical aerosols to dissolve in the mucosa. As they reach the superior zone, they bind to chemoreceptors associated with specific nerve endings. The combined message is conveyed back to the central nervous system, where it can be interpreted as aroma. Take a moment to appreciate how discriminate these messages can be. It allows you not to just smell coffee, for example, but the differences between a dark roast and a vanilla bean latte. Damage to this nerve can result from shearing forces between the olfactory bulb and cribriform plate, as can happen, for example, with severe head trauma, and leads to anosmia, which is a partial or complete loss in smell and/or taste sensation. Next up is the optic nerve, which conveys the special sense of sight through photoreceptors embedded in the retina along the posterior aspect of the eye. As discussed, the optic nerve passes through the optic canal and the middle of the posterior orbit to blend with the sclera on the back of the eye. A peculiar thing about the optic nerve, the retina itself is derived from the optic cup, a part of the embryonic diencephalon, and so the entire optic tract is considered to be an extension of the brain, rather than a true nerve in itself. For this reason, some purists will say that there is no such thing as an optic nerve, and I bring it up now so that you'll understand what it's meant if you ever hear this expression. Otherwise, don't worry about it. Most anatomists still refer to this as cranial nerve number 2, and so should you. Discussion of the microstructure of the retina is beyond the scope of the present discussion, but we will talk briefly about the different courses the axons take back to the central nervous system. Remember the optic chiasm connecting the left and right optic nerves? This represents a point of decussation in the optic nerve. And if you're not familiar with the term, it relates to the crossing of neural tracts from one side of the body to the other. You're probably familiar with the concept of the right brain controlling the left side of the body and vice versa, right? That's decussation. Decussation in the eye can be tricky to understand due to the fact that it is limited to certain axons. Specifically, the axons transmitting photoreception from the medial half of either retina will decussate at the level of the optic chiasma. Conversely, axons communicating with the lateral half of the retina will not decussate. They'll continue along the ipsilateral path to synapse on ganglia on the same side of the body. So what does this mean for vision? Let's revisit the schematic, but this time we'll specifically consider objects that appear in our right or left visual field, that is to say, to the right or left of our midline. If we follow the course of light projecting from an object in our right visual field, notice that it strikes the medial retina in the right eye, but the lateral retina in the left eye. If you follow the course as outlined in the left-hand diagram, you'll notice that all of this visual information ends up being processed in the left hemisphere of the brain. So any object appearing in your right visual field is perceived by your left brain. Similarly, an object appearing in the left visual field hits the medial retina in the left eye and the lateral retina in the right eye, and following these courses terminates in and is perceived by the right hemisphere. So let's consider what happens with certain types of nerve injuries that result in hemianopsia, or partial blindness. We'll use the stereoscopic view of the city of Paris to assist. This is a demonstration what the left eye and right eye perceive respectively. Note that these images are not identical. Because of line of sight, there are objects in our lateral fields that are picked up by one eye but not the other. This is because of the presence of the bridge of your nose. You can verify this yourself by alternating between opening the left and the right eyes while the other eye remains closed. The easiest example to consider is a lesion to one of the optic nerves, or to the eye itself for that matter, anterior to the optic chiasma. In this case, we selectively lose vision in one eye, but not the other, and lose our stereoscopic perception of the world. We also lose a portion of our left visual field. In the case of loss of sight in the left eye, we can no longer see the Eiffel Tower, unless of course the viewer were to turn his head. You can easily mimic this condition for yourself by closing your left eye. Notice that when you do this, you no longer see objects to your far left because your nose gets in the way. Things get a bit more interesting when we look at damage at other regions along the track. Take the optic chiasma, for example. This midline structure can sometimes be compressed from tumors within the pituitary gland or from an aneurysm in the anterior communicating artery. When this happens, we selectively lose the decussating fibers from the medial side of both retina. Tracing this out, you'll notice that we lose stereoscopic vision for most objects in our medial or nasal visual field. We also completely lose sight of objects in our extreme peripheral vision bilaterally due to that line of sight issue. In our image of Paris, we now not only lose sight of the Eiffel Tower, but of the Army Museum with the golden domed roof as well. This condition is referred to as bitemporal hemianopsia, due to loss of vision in the periphery or temporal region of the visual field. It's not quite as easy to conceptualize, but can be somewhat mimicked by putting your hands over the lateral sides of both eyes, similar to blinders that are used on horses to force them to look straight ahead. Lastly, we'll consider the consequence of a lesion along the optic tract posterior to the optic chiasma after decussation has already occurred. If we trace the lesion circuits back to their origin, you'll notice that we lose visual information from one side of our visual field. This condition is known as homonymous hemianopsia and is usually the result of stroke or other forms of brain damage affecting the posterior optic tract. We can now move on to cranial nerve number 3, the oculomotor nerve. We see it here passing through the superior orbital fissure and splitting into superior and inferior branches. As the name implies, it is responsible for motor innervation to a majority of the muscles that move the eye: levator palpebrae superioris, superior, middle, and inferior rectus, and the inferior oblique. In addition to the skeletal muscle innervation, the oculomotor nerve is the first of the cranial nerves we will discuss to carry parasympathetic innervation. These nerve fibers originate from a region of the brainstem not pictured here called the Edinger-Westphal nucleus, which is just above the main oculomotor nucleus. These parasympathetic fibers blend seamlessly with the remainder of the oculomotor nerve and accompanying it through the superior orbital fissure. Once in the orbital cavity, they leap off of the main nerve branch and dive into the ciliary ganglion, where they synapse with postsynaptic parasympathetic cell bodies. Postsynaptic axons then project to the posterior surface of the eye as a half dozen or so short ciliary nerves. The axons blend with the sclera and course anteriorly to innervate the circular fibers of the iris to constrict the pupil, and the ciliary muscles controlling lens diameter. Note that, although never part of the oculomotor nerve, we can briefly introduce the sympathetic innervation to the iris, which travels with the internal carotid and later the ophthalmic artery to reach the orbit and take similar paths through long and short ciliary nerves to reach the longitudinal pupillary muscle and cause pupillary dilation. Although some of these sympathetic fibers course through the ciliary ganglion alongside the parasympathetic fibers, in the case of sympathetic fibers, there is no synapsing within this ganglion. Okay, so time to discuss what happens with damage to the oculomotor nerve. Well, pretty obvious answer, right? We have problems moving the eye. We can actually take this a bit further by considering the specific muscles that are lost in third nerve palsy, and just as importantly, the muscles that remain unaffected. As we'll talk about in just a few minutes, the two ocular muscles not innervated by the oculomotor nerve are the superior oblique and the lateral rectus muscle. So what tends to happen with oculomotor nerve palsy is that these unaffected muscles have a disproportionate pull on the eye, sort of like a tug of war when one team fails to show up entirely. This results in what is known as the down and out sign, as seen in this rather creepy looking coronal MRI image. Notice that the pupil is drawn out by unopposed pull of the lateral rectus muscle and down by the pull of the superior oblique muscle. On the right, we see another patient with oculomotor neuropathy. Notice the ptosis, or droopy eyelid, because of the loss of the levator palpebrae superioris muscle. We also see the effects during active eye movements. Notice the limited upward, medial, and inferior deviation of the pupil as the patient looks about. The one motion that seems normal is lateral deviation, as this is controlled by the lateral rectus muscle. This would be the one position where the patient would not experience diplopia, or double vision, due to an inability to focus the pupils on the same object. Finally, the loss of parasympathetics leads to an inability to constrict the pupil, resulting in mydriasis, or pupillary dilation. Here we see an extreme example of mydriasis, but in this case, it's actually due to administration of a pupillary dilator. It gives you the idea, though. This pupillary response is of critical importance in neurological examinations of unconscious patients, as the oculomotor nerve is commonly affected in certain neurological conditions, and it is an autonomic response that does not require the cooperation of the patient. This pupillary response is what physicians are assessing when they shine a penlight in a person's eyes. Equal and reactive means both pupils are responding equally to the stimulus, a good indication of an intact oculomotor nerve, whereas fixed and dilated describes a so-called blown pupil and indicates a compromise of the parasympathetics and therefore of the oculomotor nerve. Moving on to cranial nerve 4, the trochlear nerve. This also passes through the superior orbital fissure and penetrates the surface of the superior oblique muscle, which it innervates. This nerve is also easily damaged due to its long course and small size, but in this instance, the only muscle affected is the superior oblique muscle, which primarily causes intorsion or rotation of the eye inward, which begs the question, why would you want to rotate your eye? This is an adjustment that our eyes make anytime we tilt our head to one side or the other. When the head is tilted towards the left side of the body, the left eye rotates, from our perspective here, in a clockwise direction. The superior margin of the eye, for example, has moved from a 12 o'clock position to a 2 o'clock position. If left as it is, things that we view would appear rotated to the right. So to compensate for this tilt, the superior oblique muscle rotates the superior margin of the eye back towards the midline in a movement called intorsion. This allows us to keep a vertical perspective on objects we are viewing. You'll notice that the opposite happens for the contralateral eye. Tilting the head to the left still creates this clockwise rotation, but on the opposite side of the face, we correct this by rotating the inferior margin of the eye towards the midline in a movement referred to as extorsion. This is the function of the inferior oblique muscle. This is the reason that you can lie down on your side and watch television, and it doesn't appear as if the characters are all walking on the walls. In a patient with trochlear nerve palsy, the eye tends to rest in an extorsional position due to the unopposed pull of the inferior rectus muscle. This results in a certain degree of double vision due to the fact that the unaffected eye rests in a neutral position. In order to compensate, patients with fourth nerve palsy tend to tilt their heads towards their unaffected side in a movement that normally generates this extorsion in the contralateral affected eye. Consequently, the unaffected eye experiences slight intorsion, as is normally the case, and the diplopia is corrected, making it easier for the patient to focus. We'll return to our discussion of eye movements with the sixth cranial nerve, but first we visit the trigeminal nerve. As you probably already know, this is a big one, so buckle up. The trigeminal nerve starts laterally from the pons, and from there it branches extensively to supply sensory and motor innervation to the face. The three principal branches, each of which we will talk about in turn, are the ophthalmic, maxillary, and mandibular branches. We'll start with V1, or the ophthalmic branch. This enters the orbit through the superior orbital fissure and begins to branch extensively to receive sensory information from the orbit. Superiorly, along the midline, we get the frontal nerve, which courses superiorly to the levator palpebrae superioris and branches further into the supratrochlear nerve medially, which passes above the trochlear hinge for the superior oblique muscle, and the supraorbital nerve, which passes superiorly along the midline of the orbit. Each of these branches continues into the anterior scalp and supplies the skin in this region. Lateral to the frontal nerve is the lacrimal nerve. As you might guess from its name, it projects to the lacrimal gland and carries the sympathetics and parasympathetics that control its activity. More on this in the next podcast. Also note, however, that this nerve receives sensory information from the skin and mucosa covering the lateral lids and eye. The deepest of the three terminal branches is the nasociliary nerve. This is located more centrally within the pocket of fat, separating out the different muscle groups, and runs obliquely towards the ethmoid, making up the medial wall of the orbit. As it courses anteromedially, it gives off the long ciliary nerve for general sensation to the eye, as well as the infratrochlear nerve for sensation to the medial eyelids and bridge of the nose. The final branch pierces the medial orbital wall and branches into anterior and posterior ethmoidal nerves for sensation to the ethmoidal air cells. Note that the anterior ethmoidal nerve continues into the nasal cavity as the internal nasal branch, which innervates the anterior aspect of the lateral nasal wall and septum. Next, we move to V2, the maxillary division. Probably the most confusing thing about the maxillary division is its position deep within the head and that several of its branches run both medial and lateral to the lateral wall of the nasal septum. These two views try to address this fact, but we need to get ourselves a little oriented first. The first on the left is looking at the external surface of the left face, with zygomatic arch and facial muscles removed, as well as selected windows of bone stripped away. The second image is of a hemisected head with a view of the lateral wall of the right nasal cavity. It's important to keep this perspective in mind that the two images are of different sides of the head. The image on the left is of the left side and the image of the right side. To further help, there is one point of continuity between these two images. This right here, the sphenopalatine ganglion, also called the pterygopalatine ganglion depending on the reference source you're using. It's found within the pterygopalatine fossa, a deep impression between the anterior surface of the sphenoid bone and the posterior surface of the maxilla, deep within the infratemporal fossa. You could think of this ganglion as being something like Grand Central Station in the New York City subway system, where numerous individuals are jumping onto cars and numerous individuals are jumping off going to other directions. Alternatively, you can think of it as O'Hare Airport, where numerous flights come in and people grab connectors to other destinations. At the present moment, the two branches we are most concerned with are the pterygomaxillary fissure laterally, where it communicates with the superficial infratemporal fossa, and the sphenopalatine foramen medially, where it communicates with the nasal cavity. Note that in this view, much of the lateral wall has been stripped away to identify inferior branches, so the red is more of an approximation of the sphenopalatine foramen. Now, I personally always thought of the pterygopalatine fossa as resembling a triangular bathtub standing on its end. The pterygopalatine fissure is like the rim of the tub, and the fossa would be the inside of the tub. You can then think of the sphenopalatine ganglion as a bather inside of the tub. The floor of the tub is made up of the lateral nasal wall, and the sphenopalatine foramen would be the drain, emptying the contents into the nasal cavity. So hopefully that gives you some perspective on what I'm trying to explain. All right, let's return to the V2 division. As you saw in the previous image, it's the middle branch from the trigeminal ganglion that exits through the foramen rotundum to enter the superior part of the pterygopalatine fossa. At this point, the nerve gives off several branches that head in numerous directions. Laterally, the zygomatic branches supply the skin over the temporal bone and zygomatic arch. Medially, a number of nasal branches course down through the sphenopalatine ganglion and through the sphenopalatine foramen, where it branches extensively to supply the mucosa of the nasal cavity. An additional branch is the nasopalatine nerve, which courses medially through the mucosa lining the roof of the nasal cavity to reach the nasal septum. So if we were to look at a coronally sectioned head on through the nasal cavity, the sphenopalatine foramen would be located somewhere in here along the lateral wall. The nasal branches would project out to the lateral wall of the nasal septum, as seen on the right, and the nasopalatine nerve would project along the mucosa of the nasal septum. Also coursing through the sphenopalatine ganglion are the greater and lesser palatine nerves, which project inferiorly through the greater palatine canal and emerge through the greater and lesser palatine foramen to supply the mucosal lining of the roof of the mouth. The maxillary branch then passes through the inferior orbital fissure to travel between the orbit and maxillary sinus in the infraorbital canal. In this region, it gives off numerous superior alveolar branches that innervate the upper teeth and mucosal lining of the maxilla. The branch emerges through the infraorbital foramen and terminates in palpebral, nasal, and labial branches that, combined with the zygomatic branches, supply the cutaneous innervation to this region of the face. We'll be returning to our discussion of the maxillary division and its interaction with the sphenopalatine ganglion when we discuss autonomic innervation in the next tutorial. For the time being, however, we move on to the third and final division of the trigeminal nerve, the mandibular branch. This is the largest and most inferior branch off the trigeminal ganglion, which dives through the foramen ovale to enter the infratemporal fossa. From here, the mandibular branch splits into anterior and posterior divisions. Little difficult to show the anterior division because it immediately splits into a number of muscular branches that serve the muscles of mastication, or chewing. This group includes the masseteric nerve to the masseter, the deep temporal nerve to the temporalis muscle, the lateral pterygoid nerve to the lateral pterygoid muscle, and the medial pterygoid nerve to, among other things, the medial pterygoid muscle. There's also a buccal branch that stems from the anterior division, but it actually doesn't innervate the buccinator muscle. It's a sensory branch that serves the mucosa on the inside of the cheek and the external surface of the cheek as well. We'll discuss motor innervation to the buccinator and the other muscles of facial expression when we get to the facial nerve. The posterior division is much more prominent in the infratemporal fossa, with longer, distinct branches. When dissecting this region, we typically observe the inferior alveolar nerve first. This is the branch that projects infralaterally and enters the mandible of the jaw through the mandibular foramen to enter the mandibular canal, where it supplies sensation to the teeth and mucosa. It reemerges superficially through the mental foramen and the mental nerve to supply the skin along the chin. Prior to entering the mandible, we observe a small motor branch come off the inferior alveolar nerve, which continues medial to the mandible in the hypoglossal region. This is the nerve to the mylohyoid, which, not surprisingly, innervates the muscle of the same name, as well as the anterior belly of the digastric. A second prominent division lies slightly anterior and medial to the inferior alveolar nerve and courses into the hypoglossal region. This is the lingual nerve, which courses between the hyoglossus and submandibular gland to supply sensory innervation to the anterior two-thirds of the tongue. It's important to note here that the specific contribution for the trigeminal nerve is completely somatic sensory: pressure, temperature, and pain. As we'll soon see, taste in this region is supplied by a branch of the facial nerve that joins in the lingual nerve to reach its destination. A third branch off the posterior division is the auriculotemporal nerve. Much more difficult to locate as it's tucked in the superior aspect of the infratemporal fossa. It's still pretty distinct though. Typically we see it arise as two separate branches that encircle the middle meningeal artery before fusing as a single sensory branch. It then courses superiorly with the superficial temporal artery, giving off sensory branches to the parotid gland and anterior portion of the ear as it travels. This is also going to be involved in autonomics, which we'll be discussing in the next tutorial. Because of the sheer number of branches, it's really not practical to discuss the clinical presentation of each and every neural lesion within the trigeminal nerve. For the most part, they're pretty obvious. A lesion to a sensory branch will affect sensory distribution from the region it supplies. I personally suffered a lesion to my anterior superior alveolar nerve following a bad sinus infection that led to loss of sensation in my central and lateral incisors for a period of a few weeks. If a motor branch to one of the muscles of mastication is damaged, it will lead to difficulty in chewing. There are other effects related to parasympathetic innervation and special sense, but we'll return to these once a few additional nerves are introduced. The one unique condition that we will discuss is trigeminal neuralgia, or trigeminal nerve pain. It's sometimes been called the suicide disease due to an elevated rate of suicides in those afflicted with the condition, due to the associated pain, anxiety, and depression. The onset of pain may be from a trigger point that can be set off with a light touch or even a gentle breeze, and the pain is often described as electric or stabbing in nature. The specific etiology is still under investigation, but one theory is of altered neural activity from demyelination of the axons, secondary to abnormal compressions of the nerve due to arteries along its route. If you watched the previous podcast, you remember that we discussed the path of the trigeminal nerve through the cavernous sinus. One theory holds that enlargement of the internal carotid artery, such as is seen with an aneurysm, may result in such a compression and lead to neuralgia. We return to the eye one last time for cranial nerve number 6. This is the abducens nerve, so named because it innervates the lateral rectus muscle to abduct the pupil when looking at something out of the corner of the eye. The nerve's not terribly well shown in this image, but is typically seen as a small branch on the medial surface of the muscle. Not surprising, damage to the abducens nerve results in loss of lateral movement of the affected eye. Consider this patient with right abducens nerve palsy. When asked to look straight ahead, the right pupil deviates slightly medially due to an uncountered pull from the medial rectus muscle. When asked to look to the left, there is no noticeable difference in eye motion, as this movement requires relaxation of the right lateral rectus muscle. The condition is most noticeable when the patient is asked to look to the affected side, due to negligible abduction of the right eye. Okay, that's a wrap up for this second installment of the Cranial Nerve Podcast. In the final installment, we'll be picking up where we left off, looking at nerves 7 through 12, which will involve a detailed discussion of parasympathetics and revisiting of the trigeminal nerve. If you found this tutorial helpful, you can help me out by clicking the like button at the bottom of the screen, and feel free to provide feedback or suggestions for future videos. You're also welcome to email me with any questions you may have, whether you're a UB student or not, and even let me know if you have requests for future podcasts, as I'm slowly planning to build up a library of these things. So until next time, this has been Dr. Stuart Ingalls, and enjoy the rest of your day.